With that, Joe, I'm going to turn it over to you and let you go ahead with your presentation.
Thanks. Well, as Steve knows, I'm a college professor at heart. And so when I get a chance to talk to groups, I often revert back to that mode. But please try to hold me honest. And if you have questions, ask the questions. I want to address the issues that you have. But having said that, I've put together some slides that I like to go over and let me know if it makes sense. If it doesn't make sense, feel free to interrupt me if something doesn't seem kosher. But let me see if I can share my slides here. Okay, can everyone see that? Can everyone see the first slide? Steve? Oh, Steve, you're muted.
We can.
Okay, all right. Well, let me get started. So the topic is opponent process and sedation drinking, but really what I like to do tonight is address a question that I hear over and over again from talking with people. And that is a certain percent of people who engage in TSM come back and they tell me, why am I not getting better? I'm taking the medicine faithfully. I'm doing everything it says in the book. Take it an hour before drinking. And initially it seemed to help, but now I seem to be stalled. I still drink out of habit. And it's gone down a little bit, my drinking, but it's still way too high. And I'm not satisfied with my progress. And so people will often ask questions in groups and talking to their clinician about why am I not getting better? And tonight, my talk is about how to address that issue. Typically, people will say things like, well, just be patient. Sometimes it takes months to get better. It took me over a year before things turned around. You didn't get this way overnight. It's going to take a long time for the brain to rewire. And so just be patient and hang in there. And so that's the advice that people are typically given in the rooms. But I like to go into a little bit more detail about trying to understand that and maybe offer some suggestions if that's you, if you're having trouble, if you're not satisfied with your progress, what could be going on, how you can understand this from a little different perspective. Okay. And I want to start with this slide, which is alcohol addiction is not caused by how good alcohol initially feels. And many people in the field will say it's the reason you get addicted is because it just feels so good. It feels so much better than anything else. But when I've talked to people who've developed alcohol addiction and I ask them how good it feels, they'll say, yes, it feels good, but they can think of other things in life that have felt very good that they didn't get addicted to. So it's important to keep in mind that I believe to understand addiction, it's not how good the alcohol makes you feel or a drug makes you feel or some behavior makes you feel good, but alcohol addiction occurs because what happens after you drink. That's the important thing. Let's see if I can. Okay. Now, the next couple slides are pretty busy and complicated, so I'm not going to spend too much time on it, but I want to show you sort of the work behind some of the things I'm going to say. People sometimes want to see my homework, what goes into my thinking, and this is a couple of slides that go into it. And so the first point is to understand addiction, it's important to understand the cardinal feature of addiction, which is engaging in using a substance increases the need or the craving to use more of it. It's a vicious addictive cycle. And when it comes to a drug like alcohol, there's two cycles involved. So that's what makes it even more complicated. And the first cycle, I call it mechanism one, has to do with alcohol stimulating the release of endorphins, which in turn increases dopamine. And that's responsible for the euphoria that you feel when you drink. I call it the positive reward, the excitement that you get from drinking. And that process, if we understand the neurobiology of it, is that the alcohol triggers the release of endorphins, which in turn increases dopamine. And dopamine helps to energize your behavior, focus your attention, and is the molecule that tells your brain, what were you just doing? Go out and do it again. This mechanism, mechanism one, really helps to explain the impaired control people have within a session of drinking. That's why 3 drinks turns into 7 drinks. That after 3 drinks, your craving for the 4th drink is even higher than your craving for the first drink. That's why people will tell me, I just intended to have 2 or 3 drinks, and I had a glass or 2 from the bottle of wine, and I wasn't going to leave the bottle, so I wound up finishing the bottle. And then I felt crappy afterwards. It's why 2 drinks turns into a bottle of wine. And it's important to understand how opponent process plays into why 1 drink turns into 5 drinks. And that's the mechanism that we normally think of when we think of the Sinclair method, that alcohol stimulates endorphins, which acts as a reward. You block the reward pathway with naltrexone. That weakens the association between the behavior of drinking and the outcome. And eventually that leads to pharmacological extinction. And that breaks the wiring in your brain, rewires your brain so that you no longer want the alcohol. And that's the model that most of us believe is responsible for recovery. And that part is true, but it's an incomplete story. And that's what I like to get across tonight. It's an incomplete story. There's a second mechanism involved with alcohol, and that is alcohol also has sedative effects. So alcohol is a complicated molecule. It releases endorphins, and that's mostly true for some people, but for virtually everyone, alcohol is a sedative. It makes you feel tired. And we think it works that way through the GABA system, where it enhances GABA activity, which causes the central nervous system to be suppressed. And that could be useful for people who are trying to reduce anxiety, or they need something to knock them out so they can get to sleep at night. And this mechanism doesn't really explain why 3 drinks turns into 10 drinks. People can control how much they drink. Typically, they drink enough to reduce anxiety. And there's a natural break on this mechanism, because if you drink enough, it'll knock you out, so it'll stop your drinking. The dopamine won't stop your drinking. Sedation will stop your drinking. And this is the mechanism that we often ignore when it comes to understanding how TSM works. And again, I said the important thing is what happens after you drink, not during the drinking, not the reward. And the way to understand it, and let me sort of give you an overview about this. When it comes to things which are pleasurable, there seems to be a mechanism where when something's pleasurable, it's also associated with pain when it's not there anymore. So, for example, you fall in love, you get married, and you're happy. Over time, maybe you're not quite as euphoric as in the initial days where you were dating, but you still feel pretty comfortable. But then if you lose your spouse, you go through a profound period of feeling sad. You miss the person. And it's like that for a lot of rewards. I know for myself, I like corn chips. And when I first eat a couple of corn chips, it feels good. But then after I slow down my corn chip eating, then I feel like I'm missing something and I want to go back and keep eating them. And it's that desire to want to keep eating them that causes the addictive cycle. And we call that the compensatory process, or the B process. And drugs that have the character of causing their own craving to want to do more, that's responsible for causing addiction. And we say the brain counteracts the endorphin surge with an opposing signal. So the endorphin crash is associated with dysphoria, anxiety, craving, and you want to have one more to compensate. You want to chase the high, chase the dragon, as they say. And when you block opiate receptors with naltrexone, you block that increase in endorphin activity. So there's no A process. And if there's no A process, there's no compensatory process. So there's no increased craving. So simple mechanism is, for alcohol drinking, if a person was only engaged in this mechanism one kind of reward pathway. Now, we'll discover later that naltrexone would be very effective in blocking the cycle where the endorphin surge elicits the craving to want to do more, and a person should be able to control their drinking better. The second pathway, the sedative pathway, is a little bit more complicated, and that is that alcohol stimulates the GABA receptor, which causes CNS depression, but your brain adapts to that. So it's like if you put your foot on the brake, your body compensates by putting its foot on the gas. And so as the GABA receptors are stimulated, your body has compensatory mechanisms where the GABA receptors downregulate and the excitatory neurotransmitters like glutamate increase. And so people experience tolerance to the sedative effects of alcohol. I know from talking with some patients that they say in my early days of drinking, after 5 drinks, I would feel tired. I'd want to stop. But later in their addiction, they could have 5 drinks and just blow right through it because it really wasn't, they weren't tired anymore. But with tolerance comes something else, and that's withdrawal. So when you stop drinking, and so these are people who drink chronically, if they stop drinking, they'll get the central nervous system then has all gas and no brake anymore. So the excitatory neurotransmitters are way too high compared to the inhibitory neurotransmitters, and you get anxiety, you get tremor, you get the typical withdrawal symptoms that we see. And then in this case, drinking may occur to suppress the withdrawal. So it's not for pleasure, it's for taking away the withdrawal. And this is a busy slide that shows what happens within a session. Initially, if you were to have a couple of drinks, you get a nice buzz in the beginning, but that buzz then stimulates the compensatory process, the B process, which is a little bit more sluggish. And what you feel at any moment in time is the sum of these two processes. So even the high starts to feel a little bit less high as you continue drinking. The first hit, the first couple of buzz really hit the spot. After a while, you're just drinking to try to maintain that high, and you never quite get there. But then, and so the motivation to keep drinking is to avoid that B state, that red curve in which you can feel restless, edgy. You just feel a craving that you want to keep drinking. And what I have to say, and this is important, is when I talk to patients, what I hear over and over again is that when people come in for treatment, often they wait a lot, years before they recognize, when they recognize that they have a problem, before they get help. And if people came in early, I think you would find that it'd be mostly that first mechanism which would come to bear why people lose control. But if you lose control, then not only do you drink a lot on the weekends, but you begin to drink a lot during the week. And then over time, that the sedative part of the addiction kicks in. So early in use, you get mostly the reward drinking, where people drink for the euphoria. But with regular heavy use, you get tolerance building up to the sedative effects, and you need more drinking to get the same effect. With chronic heavy use, you get sedative drinking. So I have patients who, I'm thinking of a patient, Susan, that I see, who, what she tells me is that early in her career, when she started drinking, she would have 3 or 4 drinks. She would feel really nice. It'd feel really good. It'd hit the spot. After a while, it would turn into 6 or 7 drinks, and mostly she would just drink on weekends. Then it became she would drink during the week. By the time she came in to see me, she had been drinking heavily for 10 years. And then she said that the alcohol didn't even hit the spot so much anymore. But if she tried to go a couple days without drinking, she would feel kind of off. She would feel anxious. She would have trouble sleeping. And the idea of having some alcohol helped her to reduce her anxiety. That's how she described it. But what she's really describing is it took away her withdrawal symptoms. And if you look at the natural progression of alcohol addiction, it can reach a point of severe alcohol addiction where you physically need the alcohol to function. And if you don't have the alcohol, even if you go one day without drinking, you have terrible withdrawal symptoms. You could have seizures. You can have severe withdrawal symptoms. You can even have confusion, delirium tremens. And so the person now is compelled to have to keep drinking, not to get the pleasure, but to avoid the bad withdrawal. So where does naltrexone work and where does it not work? Naltrexone works exceedingly well to block the reward kind of drinking. It blocks the opioid receptors so that when the endorphins get released, the endorphins don't attach to the receptors, so they don't have any effect. You don't get an increase in dopamine. You don't get that surge in endorphins, which makes you feel high and euphoric. And over time, you can get the pharmacologic extinction, where, just as David Sinclair described, the association between drinking and reward is broken. And for some people, it can occur quite quickly. The idea of drinking doesn't have much appeal. So a person, when they do have drinks, usually they're able to control how much they drink. And usually they keep it down to relatively small amounts. And for example, Susan would say that while before, when she would have 2 glasses of wine, she would never leave a bottle of wine open, it would go bad. So she had to finish it. Well, when she was taking naltrexone, after 2 drinks, she would say, well, I just don't want any more. And, she would cork the wine and save it for some other time. And that's something she never did before. As a matter of fact, later, she would have half a glass of wine and forget about it and leave wine in her glass, which is something she never did. And so for people in the early stages of addiction, naltrexone should work exceedingly well to break that first mechanism addictive cycle. Naltrexone doesn't have strong effects in terms of helping the sedation drinkers, the people who drink to take away the withdrawal, or people who drink because they want the sedative effects. Naltrexone doesn't block alcohol's ability to increase GABA activity. So people still get tired. And so over time, as a person starts drinking alcohol to take away the withdrawal, even if they're not getting so much of a buzz from the alcohol anymore, the naltrexone may be very effective in blocking that buzz. It's not effective in blocking what we call negative reinforcement, or reinforcement reward that takes away some bad feeling. So if you feel bad and you drink and you feel less bad, we call that negative reward as opposed to positive reward. And naltrexone does not block that. So a person, particularly later in their stages of their addiction, may still find alcohol rewarding, not because it produces the high and the pleasure, but because it takes away the uncomfortable feeling of withdrawal, or that what we call that B process. So as you begin to put this together, when someone says, I've reached a plateau, I'm not getting better. And so Susan would be a good example, where she was taking naltrexone regularly. She didn't get the high from the drinking anymore. She's able to control how much she drank, but she still was drinking a lot. She was stuck around 3-4 drinks every day, and she could not cut back. She was sort of frustrated with, why can't I not cut back anymore? And so while the naltrexone helped her have control over how much she drank, she still needed a certain amount of alcohol in her system to avoid the withdrawal. So if you ask yourself, what kind of drinker am I? There's ways of telling by looking at your pattern of drinking. So someone who tends to be more of an episodic drinker, someone who's not a daily drinker, it's probably still the endorphin pathway, which is motivating the drinking. If you still experience euphoria from your drinking, then the endorphin pathway is probably still primary. Sometimes people get spikes in craving, certain social, emotional situations. Often that's related to a spike in endorphin activity. And actually naltrexone is good in blocking that kind of cue stimulated craving that people get. And naltrexone is very effective in reducing the number of drinks you have per session. People on the GABA pathway, if you will, and I use GABA in quotation marks. I'm not sure it's just GABA, but the sedative pathway, they're drinking to avoid tremor, anxiety, and insomnia. They don't drink for the pleasure. And if they try to go a day or two without drinking, they can experience physical symptoms, or maybe not even significant physical symptoms, but just psychologically, they feel out of sorts. They feel a little bit more anxious, a little bit more irritable, more difficulty sleeping. And naltrexone is not going to affect that kind of craving. They're still going to want the alcohol to take away those unpleasant feelings. So treatment implications. People who are in the early stages of their addiction or tend to be the episodic drinking, TSM, daily, using naltrexone as needed, should be very effective and work relatively quickly. So these are the people who, I have patients who are younger, tend to be more episodic drinkers. They take naltrexone, and very early on, they notice that they are able to control how much they drink. They have 1 or 2 drinks. The craving between drinking sessions is lower, and they get a really spectacular response. And then there's some people who maybe that secondary kind of drinking, the sedative drinking, is beginning to come into play. And for people like that, often the naltrexone is very helpful, but sometimes they need some behavioral support. I think Katie Lane calls it meeting the naltrexone halfway. And so you can learn some strategies to reduce the stress between drinking sessions, to help you cope with feeling a little bit uncomfortable between sessions where you have alcohol-free days. And then there's some people who are clearly in the sedative drinking, and they report that they're not getting any buzz at all from alcohol anymore, that the naltrexone doesn't seem to be doing very much at all. And sometimes other medicines could come to bear to be helpful, something that reduces the excitatory system that may be hyperactive, and medicines like that stabilize the GABA receptors, like acamprosate or gabapentin, may be helpful adjunct to help people. And then there's some people who have severe dependence, and then if they try to stop, they'll have really bad withdrawal symptoms. And people in that state, it's really important to get some medical management where you can take some medicines to help take away the withdrawal symptoms so you can do it safely. The point is, once you get that sedative system under control, then the naltrexone could work even more effectively. And this is just a warning that it's important to keep in mind that if you're a daily heavy drinker, don't stop drinking abruptly. So some people think, well, my doctor told me if I take naltrexone never to drink. I heard that today. One of my patients said that they went to their primary care doctor who said, I'll prescribe the naltrexone for you, but you must never mix alcohol with naltrexone. And I don't know if they were confusing it with antabuse. And so the person went out and said, okay, I'm taking naltrexone, I'm not drinking, and then experienced really bad withdrawal. So don't do that. So let me go through a couple of takeaways. That there are 2 mechanisms that drive alcohol use disorder: the endorphin dopamine reward pathway and the GABA sedation pathway. And even though the 2 distinct pathways, they're also complementary, because the dopamine reward pathway will eventually bleed into the sedative pathway if you drink enough and you drink long enough. Within session impaired control, why one drink leads to more drink is probably best explained by the opponent process in which you're chasing the high, that you feel a little bit psychologically uncomfortable when the high starts to wear off, and so you want another drink to feel better again. And that seems to be related to the endorphin system. The between session drinking is related often to tolerance and withdrawal, and that's better explained by the sedative system. Over time, the sedative system seems to become more dominant, and then you drink to suppress the withdrawal, not to chase the high. Naltrexone is highly effective for reward drinkers. For sedative drinkers, the GABA system must be stabilized first. And people who reach that plateau, it may be because the naltrexone has gone as far as it can to help you control your drinking, but the GABA pathway is still present. And so you still need alcohol to avoid feeling uncomfortable from the withdrawal. So I'm open to some questions if you like. And um, I have some more stuff, but let me pause now to answer any questions you might have.
Yes, great, great overview. Folks, if you've got any questions or if you've got a story that resonates with you personally, with something that you heard, um, all you have to do is raise your hand and we'll give you the floor. I'll just chat for a moment as people collect their thoughts and decide what questions they might want to ask. And I just want to address the slide that you put up there. If you're a heavy drinker, daily drinker, very severe category, do not try to just go cold turkey. That almost killed me. I used to do that and it would work. It would be 72 hours of sheer hell. And then it didn't work. And I had I had seizures and ended up nearly dying. So it's very serious stuff, folks. Um, I have a question, Joe, that I wanted to explore a little bit, which is stress. Okay. When you originally did your research with the rats, you subjected them to some shocks that they were not able to control. And you were surprised to learn that they started drinking after that,
Yes.
not before, in response to that. And that led you to the idea of the endorphins being involved in blocking the endorphins with naltrexone. I'm thinking about sedation drinking and how easy it is to maybe get confused about where stress lies on that continuum. Okay. Because if I had a busy day at work, and it was a bad day at work, okay, and I come home and I'm a 5 o'clock drinker because I want to unwind from that stress, I'm probably dealing with mechanism one there, as you described it, not mechanism two, unless I continue to do that over a long period of time, in which case then it morphs over to this kind of hybrid. Is that a fair way to look at stress?
Yeah. So stress is more complicated than you think, or our preconceived notions of how stress interacts with alcohol drinking is very wrong. When I originally started doing research with rats, and this is now 40 years ago, my thesis was that the reason why people drink is to reduce stress. There was a model really prevalent at the time called the tension reduction hypothesis. But when I looked at the data, when I looked at the research with rats, there was all sorts of conflicting findings. Some people found that stress increased rat drinking. Some people found it had no effect. Some people even showed that it may have reduced rat drinking. And I said, well, let me dip my toes into the water and do some research. And I reasoned that one of the important factors that may come to play is that how people define what stress is. And at the time I was doing research with uncontrollable stress, and it turns out uncontrollable trauma has profound effects in terms of how people respond to trauma. If you don't have control over it, your response is often one of where you feel helpless, you give up. And physiologically, it releases endorphins. So it releases the normal stress hormones that we know about, cortisol and ACTH, but it also releases endorphins. And I call this the fight or flight, no pain from bite response, because the endorphins help you escape, even though you might have a broken bone or whatever. So you're not focusing on the pain, you're focused on getting out of the situation and winning the fight. But what happens is after the stress is over, when the endorphins start going back to their original low level, you don't just go back to normal, but you go back with a little bit of less than normal. You go through a little bit of withdrawal from your own endorphins. Now, how do I know this? At the time, I was doing research. I was at medical school, and during the week would be really a stressful week. And then on the weekends, I would get headaches, and I would just feel blah. I just feel like sitting on the couch and eating my corn chips and not doing anything. And it's that blah feeling that's actually closely related to endorphin withdrawal. And if I had a couple of drinks, it helped energize me a little bit. And normally alcohol doesn't energize me, but it helped me feel get better. Or if I went for a run or it's something else that got my endorphins going, it actually helped me to feel better. It gave me more energy after a run than I had before the run. And at the time, there was this big campaign to get people to drink beer where they said weekends were made for Michelob. I don't know if you remember that, but it was a big campaign at the time. And when I started looking at human drinking, most drinking occurs when? On the weekends. Weekends are clearly the most, people do the most drinking on the weekends. Now, if you're drinking to reduce stress, you should drink when you're most stressed, right? And when you're most stressed during the week. But no, people didn't drink in anticipation of a stressful week. They drank after a stressful week was over. And when is happy hour? At the beginning of the day? No, at the end of the day, after a stressful day. And why is that? And the notion was that you go through a little bit of endorphin withdrawal, and it turns out, and at the time, we didn't know all the biology of it is, but I speculate that alcohol could somehow release endogenous opiates. And there was some beginning data to show that that was true. And I said, well, if you're going through withdrawal from your own endorphins, then maybe you can compensate for that by drinking alcohol. And that's what led me to have the notion that if I gave rats naltrexone, I could block post-stress drinking. That was the thesis. And I showed that that was true. So if you block the opiate receptors, rats don't drink after stress because it was the endorphins that they were trying to get, not stress reduction. So it's really mechanism one. Now, when I talked to patients, they all said they were drinking to reduce stress. So these are people who have been drinking for years and years. And they would say, at the time, I was talking to veterans from Vietnam, and they would say, you know, when they came back from Vietnam, they really liked using alcohol. Now, in Vietnam, many of them were using heroin. When he came back to the United States, they stopped using heroin and he started drinking a lot. And they said they were drinking to reduce their stress. But if you look at it from a certain perspective, it's like all of a sudden a light bulb goes off. No, they're like in withdrawal from heroin. And instead of redosing on heroin, they were using alcohol to get their endorphins going. And then I would have patients in group therapy that would describe the experiences that they were having in Vietnam. And they would describe in detail all these horrible traumatic events. And you would think that would be terrible. But some of the patients would come out and feel good about it. It helped them to feel better when they were talking about these things. Sometimes they would even go meet up and go to the woods and reenact some of the things which happened in Vietnam. And I'm thinking, what are they trying to do? And they would say they feel calmer, they feel better when they would do these things. It's almost like they got addicted to their own endorphins. And so they would engage in behaviors to stimulate their endorphins, to put themselves on purpose in traumatic situations. And then when they didn't have anything traumatic happening in their life, you would think now they can relax, right? No, they would say they're bored. Life is dull. And they were going through withdrawal from their own endogenous opiates at that point. They were like me on weekends after a stressful week. They just felt like sitting on the couch and doing nothing. So the point is, what we think of using alcohol to reduce stress after a stressful day, it's not because we're trying to reduce the stress. We're trying to reduce the effect of after the stress. And that gets me back to the original point that Addiction is all about not that something makes you feel good, but what happens when that good thing is over. And that's what we're trying to compensate for. That's what we're trying to deal with. And so that was the insight that if naltrexone could block post-stress drinking, then maybe alcohol has something to do with endorphins. And then maybe if we gave naltrexone to humans, we could get them to drink less. And that's what led me to do the first experiment in humans. So that's a historical perspective. So long-winded answer to your question. But
Yeah.
why do people in their head think they're drinking to reduce stress? Because alcohol withdrawal from the sedative effects looks just like anxiety. It's irritability. It's sweaty. Your palms are sweaty. Your hands are tremulous. You feel out of sorts. You feel anxious. And guess what? When you drink, it does take that away. So people in their mind think, oh, I was stressed, so I drank alcohol to reduce my stress. But as we look at it from this perspective, they were drinking alcohol to take away the withdrawal. Now, how effective is that? It's not very effective because you're basically just postponing withdrawal. If you use alcohol to take away the withdrawal symptoms, when that alcohol starts wearing off, you're going to have the withdrawal symptoms come back, often stronger. It's like borrowing money to pay a loan. Yeah, you get rid of one loan, but now you owe money for the new loan that you just took out. That's what addiction is all about. Trying to pay back your current loan by borrowing money. And you're just setting up for having a bigger loan overall.
Got it. Got it. All right, we've got a number of questions here, so I'm going to start with Suzanne. She's unmuted, so you can go ahead, and I'll just try to catch everybody in order. Go ahead, Suzanne.
Okay, hi, thanks. Uh, Thanks for the great presentation, Dr. V. I'm wondering, like, if there is a certain amount of time it takes to get these systems to rebalance. Like, I probably fall in. I'm not sure exactly where I fall in between the two mechanisms. I think they're both active, but a little bit of trouble getting some alcohol-free days due to some, due to some discomfort. But how long do you think it would take in general? I know you can't be too specific for these systems to kind of start rebalancing and any other strategies to help those without, taking the gabapentin or another drug.
Yeah. Yeah. So let me answer the question this way, that if you stop drinking altogether, after about 7 days, you're past the point of having really severe withdrawal symptoms. So it takes about 7 days, maybe up to 10 days to get past the severe withdrawal, the seizures, the tremors, that sort of thing. It takes about 30 days for your brain biology to feel better. That's why sometimes we have a 30-day dry period, a dry January, something like that. Now, for some people, they have what's called protracted alcohol withdrawal symptoms, which can last up to 6 months. So I've had patients who, even after they stopped drinking, they didn't have bad physical withdrawal symptoms, but psychologically they felt out of sorts. They still were irritable. They still had difficulty with sleeping. They just, the day would be going perfectly fine, and something would be upsetting, and they would overreact to it. And those post-acute withdrawal symptoms, or was it pause, that could last up to 6 months. Now, but that's if you stop abruptly. What I've noticed that what some people do in TSM is that they don't want to go to their doctor. They don't want to take a medicine to go through the withdrawal sort of quickly. And so what they do is they taper alcohol on their own. And what the naltrexone helps you to do is you can control how many drinks you have. And so if 1 week you need 4 or 5 drinks to avoid the withdrawal, eventually the less alcohol that you drink produces less of that D process. So the next week you may only need, instead of 5, you may only need 4 drinks. to
Mm,
avoid the significant part of the withdrawal. And you can help yourself by recognizing that you may feel a little bit out of sorts, but it's a temporary thing and you'll get past it. You might use other behavioral strategies to help you feel when you feel a little bit out of sorts. You can use mindfulness techniques. You can exercise. You can um, do deep breathing. So there's other ways of coping with feeling out of sorts, feeling anxious, rather than redosing on the alcohol. So you can use medicines to help block it. You can use certain behaviors to help you get through it. And then if you discipline yourself and you monitor your drinking, then the 4 drinks turns into 3 drinks, turns into 2 drinks. And that B process keeps getting smaller and smaller because there's less of the A process to trigger it.
great.
So hopefully that answers your question. So that's
Mm,
the part where people often feel that they're at a plateau because they don't see their drinking going down very quickly. But if you're willing to tolerate feeling a little bit uncomfortable, not so much that you go through bad withdrawal, but a little bit uncomfortable, and you keep track of it, you may be able to just gradually taper on your own. Now, there are some people who say, look, I just don't want to do it that way. I think somebody said they're 70 years old and they don't have 3, 4 years to go. So you can do something that helps to sort of reset your brain. And so doing a ambulatory detox, and you don't have to go inpatient to detox. I've shown that in a study conducted like over 30 years ago. You can do it in an ambulatory setting. Right now, in our program at the Volpicelli Center, we have 2 people detoxing right now, and they came in one day, and the rest of the detox, we're doing it over the phone. We're doing it through telemedicine, and by next week, they will be detoxed, and we've done that on numerous occasions. So you can do it that way, and it's not that hard, and the medicines are pretty benign. And so some people just like ripping the band-aid off all at once, and after a week or two, they're good to go on naltrexone, and the naltrexone can work even more effectively. So that's 2 different strategies: to rip the band-aid off slowly or to rip it off all at once.
do you ever use any like dietary supplements to help get through the
Mhm.
tapering?
Yeah, so my colleague John Umbrow, he would say that it's important to make sure you have plenty of protein to help you, that can help take away some of the withdrawal. And then he would also suggest that you have the omega 3s because alcohol affects your brain and it basically is a solvent, so it dissolves fat, and your brain's mostly made up of fat. And so to replace that, you need good omega 3s to help your body recover quickly. So supplements can be helpful. Behavioral strategies can be helpful. All those things can work together.
Okay, great. Thank you so much.
Great. Pam, you are next. I'm going to ask you to unmute.
Yeah, actually, Dina was next. Sorry.
Oh, I'm sorry. I'm
And
going to
I'll unmute her.
Dina unmute.
Hi there. Um, so oh no, I can't see the doctor. No,
Uh-oh.
there you are. Okay. I have been on TSM now for 2 months, and I feel really blessed because I'm super fast responding. I was a reward. My issue was that I would drink very fast, and I'm very small, so I would black out on a very little, like 4 drinks. So I was very getting really scared of the blackouts. Since I've been on TSM, I have not had a single blackout. Um,
Beautiful.
and it's incredible. Like I have complete control over how much I drink. And it's usually around 2, sometimes 1. Um, I don't, I have more alcohol-free days per week than I do drinking days now. I guess my question is kind of like,
So you're a perfect example of that first mechanism kind of drinker. So
okay,
perfect
yeah,
example.
yeah. And so, my what would happen before when I would quit drinking, it was easy for me to quit. But
Hmm.
what would happen, and I thought that was interesting, the protracted withdrawal thing is like at about this, I would say like 6 month mark, I would go
Hmm.
into deepest depression and become antisocial. It just was like really not a good quality of life. So with what I'm doing now, I don't have any depression at all. In fact, I feel better than I've ever felt in my entire life. And so I'm just sort of wondering, like, should I just keep doing like, will I just, is it okay for me to just do this like this for the rest of my life? Just take a pill every time I drink, or will I
Yeah.
act
I,
ultimately?
I, I can tell you what mostly happens is that people do this and they don't feel guilty about their drinking. The life is much better. People around them appreciate that they're not drinking so much. And over time, alcohol means less and less to you. And sometimes people just wind up quitting, even though that's not even their initial intention. It just something that they just don't do anymore. But it's not that they're working at it, they're not white knuckling it. It just that's how it evolves. So I would recommend though that for health reasons, it's important to try and get your drinking to no more than say 2 drinks in a day. For females, probably even 1 drink is safer. But if you have 1 drink a couple times a week, it's probably not horrible for you. And probably with the naltrexone, you'll be able to continue that pattern. I don't know,
Yeah.
is that your goal? What is your goal?
Well, I think the goal was to stop blacking out.
Yes.
Um, and the goal was to be able to control the drinking.
Hmm.
Uh, I don't really want to be abstinent,
Okay.
just because there's just I don't know, I really like doing certain things
Sure.
kind of involved. Like I love wine tasting. I
Hmm.
love I love tasting craft beer.
Sure.
Um, I love music with a couple drinks. But yeah, I mean, ultimately, I would say that my drinks per week are still probably higher than the standard.
Hmm.
Uh, so it's probably like you just said, for health reasons, I should probably,
Yeah, I mean, you probably have some measure of control of your drinking, and like people who don't have an addiction, they might be drinking too much because they don't realize that, 14 drinks in a week is probably not more than 14 drinks in a week is probably not healthy for you. And then you say it's not healthy for you, try and limit it, and people then limit it. But now it's your choice, not a compulsion that you have to do it. And it feels completely different that you don't feel like you're giving up something in your life. It feels like you're making intelligent choices for what's healthy for you.
yeah. Okay. Yeah. Well, I really appreciate you being here. It's amazing medicine.
It
Hey,
is. It is.
excellent. All right, Pam, I think you are
Hey,
next.
I'm sorry. I was just
Okay.
in a, I was a placeholder here just for Zoom user who wanted
Oh,
to ask a question. And then Pam was straight after, and
okay.
that's the order. Yeah.
All right. So, Zoom user, you are next. I'm just looking to see.
So I see her comment in the chat.
Yeah, I see the question in there, but I wish I had this information about heavy drinkers earlier. My doctor would not let me detox at home, and I was stuck in a cycle and not getting anywhere. Thus, the trip to Mexico. I assume that was a trip to get a detox, maybe.
I began.
Not sure what the question is in there.
So
I don't know how to get to. Please,
Go ahead.
this is Pam. Are you talking to me right now? Yes.
Oh no, I think we're going to move to you. Yeah, because I'm not hearing anything from Zoom user. Although
Okay.
Dave.
and the chat Zoom user says that she got ibogaine in Mexico.
That's me. That's me,
Oh,
Pam. Yes.
Okay.
I didn't know. I
great.
don't know how to use Zoom too well, so sorry.
No worries. Go ahead, Pam.
Well, I wish I'd known the heavy drinking information earlier. I was trying to get information right and left from everybody, and I couldn't get it. And so I just got desperate and went to Mexico and got this treatment for ibogaine. I don't know if anybody knows what it is, but it is a miracle because I haven't drank in 20 days, no cravings.
Hmm.
You don't have withdrawals. Um, but I want to continue with TSM, and I don't know if my doctor said don't do now, don't try to tempt fate and drink again. I don't know what to do if that's my safety net would be like the now and the TSM, or just give everything up on that end.
So the ibogaine is a really interesting molecule that looks like it sort of takes away the B process, if you will. And it works for alcohol. It works for opiates as well. I've had patients who've gotten ibogaine treatment, and it took away their severe withdrawal,
It's a
like
miracle.
immediately. There's actually on Saturday, there was an executive order that President Trump just signed to say he's putting like $50 million into research on psychedelics, which included ibogaine.
Hallelujah.
In fact, he mispronounced the word. He said, whatever. He didn't pronounce it correctly. So it's a really hot area for research right now. As a matter of fact, I just read a paper today where they did a placebo-controlled trial looking at ibogaine to treat depression. And in this paper, it didn't quite meet the statistical significance that they were looking for their endpoint because they want to get FDA approval. And unfortunately, there was a couple of cases where there was people had bad trips, if you will. But so even though it didn't quite meet statistical significance, the trend was clearly present that it helped people with depression. So it looks like it may help take away withdrawal. It looks like it might help some people with anxiety, and it might help people with depression. I know I've done work with some patients where we've used other psychedelics. For example, there's ketamine, and I've worked with some patients and I've seen remarkable success. I've had a patient who had chronic depression and my antidepressants weren't working, had problems with alcohol, and he kept going back and forth between drinking and feeling depressed, and he couldn't break that cycle. And he went through a trial where he took ketamine, and after a cycle of ketamine, he just felt 100% better. And he went through a divorce. He has a new girlfriend now. He's really happy. He doesn't crave alcohol. He's been doing really great. And so there's something with the psychedelics that it's sort of, they say it resets your brain, increases neuroplasticity. The way I would look at it is it takes away that B process. It's like if naltrexone is a blocker of the A process, this is something that sort of blocks the B process, if you will. But there's so much more that we need to learn about it. But there seems to be something interesting going on there. So I'm not surprised. So getting the ibogaine is like going through a quick detox, and it sounds like it worked great. So the question now is, now that you've detoxed, is it okay to drink? So if you just have the detox and go back to drinking without naltrexone, the prediction would be you could get back in that addictive cycle again. So you still have that first mechanism, if you will, where the one drink could turn into a lot of drinks. And over time, that could lead to getting that second mechanism come to play again, and you'd be back to where you started. So the doctor's suggestion is don't have that first drink.
Yeah, one thing I just wanted to say was my plan was not to drink again really at all because I don't want to, but I would like to, if I was at a wedding or some type of a function, be able to have one drink and just that's it, just for that.
I would strongly recommend that you have naltrexone before you have that one drink. If
That's
you decide to have one drink. And let me ask you, so before, how long are you in your journey with alcohol problems? Has it been relatively
forever, 40
recent?
years, 40 years,
Okay.
40,
So
24/7 drinking from a lot of it.
So in that chart that I had, you would be at that part of
Yeah.
the spectrum where probably both mechanisms will come to play. If you have a detox, now you go back to that first column
Okay.
where the naltrexone should be spectacularly effective for you. So
That's what I
if
heard.
you can remember back to when you first started drinking, was it a pattern where 2 drinks would turn into 5 drinks?
No, when
No?
I very first started.
Okay.
It was a gradual thing with me, and then boom,
Yeah.
grabbed me.
Okay, so some people, and this is important to point out, that they don't get to that sedative drinking phase through the endorphin mechanism. They might start with that sedative phase just because they enjoy the sedative effects of the alcohol. And again, they drink because it helps them to, sleep, or it helps them to feel less neurogenergically hyperactive, if you will. And so the naltrexone might not be helpful for you. So we don't know. So I guess a prudent thing would be not to pick up any alcohol. But I would say if you do, make sure you take naltrexone first.
But if I never reached extinction, before I did the ibogaine, does that matter? Because I did lower my drinking some, but not enough. I was still
Yeah.
drinking way too much before I went and had that done. And I've been trying to talk to you, and I don't have the right program at Thrive to be able to tune into you, I guess. And I've been desperate to find from somebody what I didn't want to go do that treatment because it is dangerous. And I'm 70. This is why I did
Yes.
it because I don't have I don't know how much time I have at 70. I'm healthy, but
Well,
it
I'm
just,
older than you, and you have plenty of time, so
oh, I
don't.
think so. But I mean, I was afraid to wait 1 or 2 years for extinction. You know what I mean? And I just needed to get it going.
Well, yeah, you needed to rip the Band-Aid off all at once. So I agree with you, and that's a
So
good strategy.
not, I mean, no medical, I guess, advice, but you're saying I don't take naltrexone every day or anything, just keep it with me if I wanted to do that. And you think I'd be safe even though I didn't reach extinction? You
So
think I would be safe
the
if I took the one?
safest, the safest thing to do would be
Oh,
not to risk getting back in
okay.
that addictive cycle by having one drink.
So it
That would
sounds
be
like
the
I should just
safest thing to do.
don't do TSM then. I guess I'm just dropping out. I don't
Well,
want to. I don't want to.
if you experience craving, I
Okay.
would take the naltrexone because it
Okay.
can help reduce craving. If you're in a high risk situation where you might drink, make sure you take the naltrexone ahead of time, but you don't have to drink. Uh,
Good.
Maybe if
Yes, I know
Steve
that.
invites me back again, I'll spend some time talking about the various ways naltrexone works. And it turns out it works through three mechanisms. So there's the traditional mechanism that David Sinclair popularized, which is it breaks the association between your behavior and reward.
Hmm.
And and so the responsive drinking is no longer followed by reward, and that sort of loosens that association between picking up a drink and expecting a reward. And if you take out the reward, then that behavior gradually extinguishes. So that's one mechanism. But just to give you an overview, there's two other mechanisms. One is that, and this involves associations, but not between your behavior and rewards, but associations in the environment. That if a cue is associated with drinking, that cue can elicit craving to want to drink. So
Yes.
if walking into a bar could elicit craving to want to drink. When it's 5 o'clock and you're used to drinking every day at 5 o'clock, when five
Yeah.
o'clock comes around,
Makes
you have craving to want to drink.
makes sense.
And those cues can be blocked with naltrexone. So that's the second mechanism. The cue associated craving can be reduced with naltrexone. So that doesn't involve having to drink after you pick up alcohol. After you pick up a glass where you have to drink it to extinguish it. No, this is extinction between cues out in the environment.
Oh, cool. Okay.
And then there's a third mechanism, which is doesn't have to deal with learning at all. And that is when you drink and you have a release of endorphins, which increases dopamine. What does dopamine do? It tells you, go back and do that again. And when dopamine levels start to drop, that makes you feel a little bit uncomfortable. You want to chase the high. So if you drink on naltrexone and you don't get the endorphins released, you don't get the high dopamine, you're not going to have that craving to want to keep drinking after one drink. And that doesn't involve, that occurs the very first time you take naltrexone. You don't have to learn that. That's just a basic non-associative biochemical effect. If you don't have the dopamine, you don't have that craving where you want to keep drinking after the first drink. So those are three different mechanisms. And one of these days, if you like, I can go into more detail about that and how each one works. But so you don't have to get better from naltrexone. The point is just by pairing the act of picking up a drink with actually drinking and showing that you don't get any reward.
That helps. That helps me very much. Thank you. Very much.
Yeah, and just further on that, I guess I would say I've never taken naltrexone. Okay, if you know my story, I mean I've been alcoholic all for you.
Let me before you go on, I just want to say, if you want to know his story, check out a fantastic essay he wrote on my Substack. You can hear Steve's story. Okay, that was my plug.
Yeah. So
Volpicelli, Substack.Volpicelli. Go see his story.
yeah, it's actually on Discord too.
Oh,
So you can get
fantastic. Go to Discord.
but so I haven't had anything to drink for 14 years almost now, and it was because it almost killed me. Okay, and I have no desire, I have no cravings. I wouldn't go back to drinking for any reason that I can think of. But if I were going to go entertain that idea, I would be getting some naltrexone immediately, and not only I wouldn't necessarily wait. If I really felt that I was going to go that path, I wouldn't really wait to have that instance come before me. I would probably want to see what is my reaction to the naltrexone. Okay, maybe take a little bit and see, do I have a reaction? So if you have no history of it, Pam, and you're thinking about, oh, I might want to do this, you might be well served to try a little in advance of actually that wedding or whatever instance where a drink is going to be thrust into your hand, and you need to make a decision at that point. In other words, you've thought it out and have a process in place to prepare for that, I guess is what I'm saying. We have a question from C. I'm going to unmute you or ask you to unmute C and ask your question directly. I see it's in the chat, but if you can.
Yeah, I'm having a bit of a hard time with all of this. It feels very complicated. When I think of why I drink, sometimes it's social, but then yeah, it feels good, so I keep going and overdo it. But a lot of times, most of the time, I'm drinking to self-medicate, to get rid of anxiety. And I'm just the ibogaine is something that I only heard about for the first time yesterday. I guess my question is, if you're saying for someone like myself that's maybe on, I don't know, somewhere along the spectrum of both categories that you mentioned at the beginning, if like the combination of naltrexone and ibogaine could be helpful.
Yeah, no, for sure. Now, the only thing I would say about the ibogaine, it's right now the idea of using psychedelics is a really fascinating topic, and it's getting a lot of press, a lot of interest. But what I would say is that we already have safe, effective medicines right now that don't involve where you have to go to Mexico to get the ibogaine, that have been well tested and work. And so my first recommendation would be not to immediately jump to the ibogaine, but to use some of these well-tested medicines, like you can use benzodiazepines like oxazepam, you can use Neurontin, you can use Tegretol. And there's very simple protocols that a doctor should be able to do right in his office in a primary care setting. Now, when I talk to patients about this, a lot of them say, I don't want to go to my doctor and tell them that I have an alcohol problem. And I ask, why is that? And they say, well, I feel ashamed about my drinking, or I don't think my doctor would understand. There's a variety of reasons why that occurs. And that's sort of one of the subjects of the Substack series that I'm writing right now, is that the medical profession is really failing at addressing alcohol addiction, because people should feel very comfortable saying, I have an alcohol problem, can you help me? And they should be very familiar with being able to treat it and be able to go there in a non-judgmental environment to say, okay, this is what we do. It doesn't have to be all or nothing. Even if you have a slip, it's not the end of the world. We'll deal with it, just like treating diabetes or any other medical condition.
Did you say benzos in there?
Mm-hmm. You can use benzodiazepines like oxazepam, yep,
Okay,
or Librium or whatever.
like lorazepam, for
Yep.
example.
Mm-hmm.
I find it very hard to get prescribed, and I thought that it was very dangerous to mix, lorazepam and alcohol.
Well, you don't want to mix it. That is if you're going to detox.
Right.
So the instruction would be don't drink alcohol,
Right.
rather take the lorazepam. Because if you mix them, they work together, they work synergistically. I don't know. Does anyone watch the Pit, the television show The Pit?
Should we?
I don't know. It's a little too realistic for my taste. That for me is like, am I going to get CME credits for this? But there is a storyline of a patient. I forget his name, Clarence or whatever, and he was a elder black man who had severe alcohol addiction, and he come to the emergency room uh, because he had ascites, he had all these medical problems, and they would all address his medical problems, but never get him treatment for his addiction. And then eventually he died. His his liver failed. He had pulmonary embolism and hemorrhage and died. And then they sat around. They said, "Oh, this guy is such a nice guy," And it made me so angry because they would give him medicines to help him detox and then send him home. And no one throughout the show ever talked to him about going on naltrexone. Now, if they would say, well, he wasn't interested in stopping. They would say, you should quit. And he goes, well, I don't feel like quitting. Well, what he's saying is, I don't think I can quit. What else? What's out there for me to quit? It's too hard. And the guy
Yeah.
was also depressed because he went through some trauma and all that. No one ever sat down with him and said, look, here's a way to get better that doesn't involve you having to go away for 28 days, doesn't involve you having to necessarily turn your will over to a higher power and go to meetings every day. Here's a medical condition that we can treat. I mean, if you went in there and you had a heart attack, but they say, here, take some nitroglycerin tablets and make sure you cut back on your fats and carbohydrates and all that, you would be sent to a cardiologist.
I
You'd
mean,
go
that's,
up you go up to the floor and manage to make sure you safely recovered from your heart attack. And then before you left the hospital, you have an appointment to see a cardiologist.
yeah.
But they don't take this disorder seriously like that. And it makes me so angry. And so the system fails. So when you say, I'm not going to see my doctor and talk about it, for me, it sort of reinforces that attitude that this is something that you should hide. It's something that we don't have to put responsibility on the doctors to treat. They need to hear from people. This is my problem. It's a medical problem. I'm not going to be embarrassed about it. I expect that you're going to be able to treat this like you treat other medical conditions. And if you can't, I'll find another doctor who can. And eventually that will help compel the doctors to change their attitude about it. I talk to some doctors and they say they're afraid to bring it up because they would offend their patient if they even asked about drinking too much. But it should be a routine part of basic medical visits to ask, are you having trouble with controlling your drinking? Do you have times where you have 5 or more drinks in one setting? Let's look at it. Here's some of the medical consequences of it. If you'd like to cut back, here's a medicine to help you cut back. Well, we don't do that. And that's what's very frustrating for me. So, so the fact that people will try to taper on their own and know that it's going to take a year or so to get to a point where they can control their drinking to a point where they're drinking at safe levels, to do it that way versus going in for a 1 week detox is appalling to me. Okay. I'll get off my soapbox.
I echo that. I mean, I went through what I went through, and I was never offered out naltrexone, never. So I understand and agree with that. Jack, you're up next.
Hi. Can you hear me?
Yep.
Yeah. Yeah, so I can relate to this. The naltrexone works really well for me, but I struggled for 4 or 5 months of just the withdrawal, and I don't think I realized I was having withdrawal at the time, but it had significant withdrawal in the past. And so I forced myself to go several days without alcohol, and since then I've only drunk socially, and the only times I've craved alcohol is when I've overdone it the night before. I was just wondering what you know about the kindling effect, or why somebody who's already experienced severe alcohol withdrawal um, is susceptible to that so much more quickly than somebody who hasn't.
Yeah, no, what you report is absolutely true that once you've had bad alcohol withdrawal, the chance of having bad alcohol withdrawal again in the future is much higher. And kindling means that that B process, if you will, gets kicked in harder and faster the more times you have it. And then that seems to be a basic phenomenon of the B process. It just tends to kick in harder and faster each time you go through it. And so, for example, people who had an alcohol withdrawal seizure, if they have that in their history, then I automatically know that going through the alcohol withdrawal now is going to be a tough process. So normally people can safely detoxify in an outpatient setting, but if they've had an alcohol withdrawal seizure in the past, that's when, it's often better to be in a controlled setting to help monitor your symptoms so you don't have alcohol withdrawal. But so the system that counters the sedative effects of the alcohol gets stronger and faster over time. And we call that kindling. And
Yeah.
by our model today, it means the beat process is getting stronger and faster the more it gets exercised.
So even if somebody were to give up alcohol for a significant period of time, they'd still be susceptible a lot more quickly than somebody.
Mhm.
Yeah. Okay.
It's almost
That's
like the
that's
beat process is learning. It's like your immune system. After you've been exposed to a measles virus at a certain age, could be 20 years later, if you're exposed to just a little bit, the immune system kicks back really strong because it remembers that it saw that virus before.
right.
All good, Jack?
Yeah. Thank you. I really appreciate it.
All right, great. Sandy uh, asks in the chat, where can I get gabapentin prescribed online?
Yeah, so gabapentin used to be a medicine that we thought was incredibly safe, and we were using it for everything, for migraine headaches, for anxiety, for alcohol withdrawal, for neuropathy. And then some people began to abuse it. And now the pendulum has swung the other way where, it can be harder to get. And in some states, it's actually a controlled substance because some people have abused it. And so it's going to be harder to get gabapentin online these days. I bet if you try hard enough, you can find someone who's willing to prescribe it, but it's not going to be like naltrexone, which has no abuse potential, not a controlled drug. And in fact, some people recommend it should be over the counter. That's how safe it is. But gabapentin is not over the counter. It's in some states it's a controlled substance, which means they keep track of it, and you need a doctor to prescribe it.
All right. Joe, we'll go to you next. If you can unmute and ask away.
There it goes. So I have a really quick question just listening to this, that I've only been on naltrexone for 2 months, just a little, 2 months and a couple of days, and haven't really experienced much of a change other than alcohol's not much fun anymore.
Mhm.
Um, and so I'm curious, what is that like? Some people respond very quickly. Some people I've heard don't expect anything for the first 3 to 4 months.
Mhm.
I think I just heard you or somebody else say like a year. I'm like, oh shit. Like, do you, when have you hit a plateau where naltrexone's just not working for you? Or when is it just, you just need more time?
Yeah. Well, so that's your perfect example of what we're talking about in the today's talk. Do you tend to be a daily drinker?
Yes.
Yeah. And so probably we have two mechanisms at play. The first mechanism, which is the alcohol produces a reward, and probably, correct me if I'm wrong, early in your career, the one drink turned into a lot of drinks. Maybe you started just drinking a lot on weekends, and then it gradually morphed into daily drinking. And so at this point, we have the first mechanism, which naltrexone can control easily, and then but we also have the second mechanism, which is the drinking to avoid the withdrawal mechanism. Now, theoretically, if you're reporting that the alcohol doesn't make you feel as good anymore, and you don't get the high like you did, theoretically, you should be able to control the number of drinks you have per drinking occasion. And can I ask you about how many drinks you have per drinking occasion now?
Between 5 and 6.
Okay. And are you able to keep it to 5 or 6, or does it bleed into 7 or 8?
Depends on the day.
Okay.
I think it was funny after I started taking naltrexone, I had like a period where I literally felt like I was drinking more than before naltrexone.
Yeah.
And then that sort of has been dying off. I do use the app to track everything, and
Mhm.
I'm noticing it's trending downward, which is great, but not necessarily like the stories I hear from other people.
Yeah.
And so it is trending down. I am drinking less. I'm much more conscious. I'm um I'm not necessarily discouraged, but I'm like I I hear all these lovely stories that sound so inspirational, but they also don't seem to be the reality. The reality seems to be like one of the hosts of the TSM meetups told me like don't expect anything for 3 months. And I was like, okay. And so, but then I also hear these people that are like, oh, 2 weeks of naltrexone and I just don't want to touch alcohol again. And I'm like, oh, that's just lovely. Like, but it doesn't seem like reality. And so what's reality?
So both are reality. That's the whole point. And when and you're a perfect example that you have two mechanisms at play here, and your pattern fits the model perfectly. That while you may be able to control how much you drink, your body still needs a certain amount of alcohol in it to avoid the withdrawal. But what it sounds like you're doing is you're able to moderate your drinking where you gradually are cutting back without going through bad withdrawal. Now, if you can throw in an alcohol-free day now and then, that's going to help speed up the process. If you can uh, tolerate a day where you feel more out of sorts and realize that your body's going through withdrawal and it should be okay, then that's going to help speed up the process. Or you can say you're going to take it at a slow rate, and what should be happening as your A process isn't getting stimulated as much because you're not having as much to drink. The B process is not going to be kicking in as hard. So eventually you're going to get rid of that B process and be able to moderate your drinking down to 1 or 2 drinks a day. So there's certain things you can do to speed up the process by having more alcohol-free days thrown in there. Um, monitor your drinking, and see if you can each week cut back a little bit more each time, and realize that even if you don't feel 100%, you're doing good work so that you're not borrowing money to make your loan tomorrow higher than it is today. You're gradually paying back that loan. If at some point you feel like, this is just dragging out too long, I'm tired of this, then go through a detox. Take some medicines to help make sure you safely can get through a period without any drinking. Give yourself 30 days with no drinking. And then if at that point you want to be able to drink occasionally or as often as you like, but keep it just to 1 or 2 drinks, and you take naltrexone first, that's a perfectly acceptable outcome too. And many people have done that. Hopefully that answers your question. Here's the bottom line. Your experience is not a failure of you. It's not a failure of naltrexone. It's data. It's you're responding exactly as the model would predict. It's a diagnostic tool of what kind of problem you have with alcohol. And you have two things at play. One, if you detox gradually, it's going to take you more time, then the people who don't need to go through a detox, the naltrexone is going to kick in right away, and they're going to have that miraculous effect right from the very first time they take naltrexone. And both things are true, and both things are reality. It depends on where you are in your, journey of drinking.
Right.
Does that make any sense to you? Or?
Yeah. And it confirms like some of the things, like I know some of the things I've done over the past few months is like mostly give up liquor and only drink, and then I
Right.
then I switched from like
Perfect.
regular wine to
Yes.
like the really like low calorie, low
Yes.
alcohol wine, which really sucks.
Yes. Yes.
But
You're
but
not
I'm just
drinking for
doing
the
the
fun.
things to lower the
Yes.
to
Exactly.
just
You
keep trying to
need
lower it.
a medicinal dose of alcohol in your system. You're not drinking to get the buzz. You're drinking for a medicinal dose of alcohol to avoid feeling crappy. And see, when people understand this model, all of a sudden they look at their drinking completely differently. When before people understand this model, they'll say they're drinking to reduce stress, or they'll say things like, "I'm drinking out of boredom," or "I'm drinking out of habit." Their cognitive brain is trying to make sense of what their limbic brain is doing. So they come up with all kinds of rational explanations. And usually it's wrong. When you understand the model, it's, oh, what I'm doing is I'm drinking enough alcohol to avoid feeling the withdrawal. And now I have some measure of being able to control how much I drink. And so I'm not even drinking to get the buzz anymore, the pleasure. I'm drinking to get a medicinal level of alcohol in my system so I feel better. And I'm going to continue to cut back on my drinking so that next week I won't need as much alcohol to take away the withdrawal because the withdrawal is gradually going away. And then it feels completely different. It feels like, oh, I'm on a successful journey. I'm not, the naltrexone not failing. I'm not failing. The process is not failing. It's playing out exactly as it should.
Which is sort of like stay the course.
Yeah.
It's,
Or
I'm,
change
I'm
the course if you want to rip off the Band-Aid faster. It's your choice now. You're free. The naltrexone helps give you the freedom to make that choice. Without the naltrexone, your limbic brain just has, goes wild, and it's going to tell you how much you drink. Right now, you can tell yourself how much you drink. That's what the naltrexone gives you. That's the gift of naltrexone.
yeah. And I have not introduced alcohol-free days, mostly out of just like fear of not being able to do it or,
Yeah.
you know.
It's, well, yeah, you want to avoid having the withdrawal. That makes perfect logical sense. When you reach a point where you're willing to do an alcohol-free day, or you're able to do an alcohol-free day without feeling miserable, then that will help speed up the process of getting your body used to not having alcohol in it anymore.
Yeah. I think that's got to be the next step to speed things up.
That'll speed things up.
Cool.
Yeah,
All right. Thank you
I
for that. That's really
can't
helpful.
I can't stress enough how how personal an AUD is for someone. Okay, and by that, what I mean is, like, if we look at the real extreme ends of some of these of this spectrum we're talking about, it takes somebody who's really, really new in their drinking career, but when they drink it, one drink, it's like it turns into five immediately. Okay, it's a binge drink. Okay, but they're 20 years old or whatever. They're probably heavily influenced by the mechanism one at that stage. Okay, so now naltrexone is going to look like a miracle cure to someone like that versus someone that's been drinking for 30, 40 years, mostly sedation style, where we know that naltrexone is going to help somewhat, but there's going to be a lot of other things that are going to be going on that could take a long, long time. Okay, and those are both true because that's the individual. And then we throw salience networks and everything else into there with triggers and everything else. And, you can see how complicated it gets. So I love Joe's point is that, it's not a failure, it's data. With that, let's see. I think then I'm kind of losing track of who's next, but I think Suzanne, you had a follow-on question. Suzanne, can you unmute?
Sorry, I did the microphone, but didn't do the message thing. Just one quick follow-up. The From what I hear, I think I'm kind of where Joe is now. In the process, only I'm about a year or more. I'm about a year into the taking naltrexone. So I think that what you said is just to pay down the loan and to try to get some AF days and maybe treat the discomfort with one or two instead of five would be the right way to taper down.
Yeah.
Okay.
Yeah.
The other that's just brilliant about the loan. Now I really get it.
Let me just say this about the loan.
Okay.
The word addiction actually comes from Latin, which it comes from addictus, which was a legal ruling where someone who owed someone else money got addictus to that person.
You're
So
kidding.
so it basically became a slave to the person that they owed money to. And usually that came about because somebody was gambling. That's how they borrowed so much money to pay their gambling debt. And the loan shark then would keep, lending them money to pay the loan, and the guy would get further and further behind until he became addicted to the person who was lending him the money. And that etymology is just a perfect way of describing what addiction is.
Yeah.
I just love that.
So you just pay down your loan a little bit at a time, and pretty soon you'll be free of owing
Yeah.
money.
Yeah.
Okay.
Yeah.
Or pay it all off at once.
Or pay it. Yeah.
If you can do that.
You can do
So,
it.
regarding
But-
ketamine, the ibogaine, I,
Mhm.
that story is amazing. I've heard about ibogaine. I've heard it's also a really, really tough. It can be very frightening to take it. Um, and also a lot of the literature, or maybe it's just anecdotal actually. If you're drinking, you need to clear your system out of alcohol before you take ketamine or ibogaine, but doesn't sound like that's true.
Yeah. Yeah. You don't want to mix the two. So first you have to stop drinking, and then you're going to feel horrible withdrawal. Then you take the Ibogaine and it takes away the withdrawal. And then after that experience, theoretically, you don't want to go back to drink.
Uh-huh.
That's the theory. Yep.
Okay. How about ketamine? Do you have to?
It's really interesting. There's some data that it can be very helpful, but again, you can't mix the ketamine with the alcohol because for ketamine to work, you can't be intoxicated.
Right, but you have to
It messes up the mental state that the ketamine is trying to induce.
But would you have to be off of it for like a day, several days or a week before you would take ketamine?
So most people who are prescribed ketamine would want you completely detoxed off the alcohol first. Yeah.
Okay. Okay.
Yeah.
That's just this one of those, like, if I could, I would, but if
I know. I know.
I mean, I just want to get there.
It's interesting because I've been treating patients for many decades now. And when I tell people, look, don't drink, and I say, how can I not drink? I say, because I know for you, part of your motivation to drink, and not, I'm not even talking to your cognitive brain now. I'm talking directly to your limbic brain. Limbic brain, I know you're afraid of feeling crappy if you don't drink. You're worried your body's going to go through terrible withdrawal. You're going to have craving. You're going to feel completely out of sorts. Let me help relieve that anxiety right now. If I give you this medicine that takes away the withdrawal, you're not going to have those feelings. But do not mix the two. Take the medicine as I prescribe it, and you'll do fine. And for most people, I would say 80, 90% of people, they take the benzodiazepine or whatever medicine I'm prescribing, and they only have to be on it for 3 to 4 days. And at the end of it, they feel fine. Now, just doing that doesn't take away the cue stimulated craving. So they're still very susceptible to relapse. It doesn't take away when they go out with their buddies and everybody's drinking and they want to have a drink. It doesn't take away when they do have a couple of drinks that the couple of drinks doesn't turn into 5 drinks. So the detox is only one phase and by itself is not a very effective treatment, but it then gets you one step closer where if you then take naltrexone, those cue stimulated cravings go away. The 2 drinks doesn't turn into 7 drinks goes away. The combination is incredibly effective. And that's what I do routinely in my clinical practice. But I do understand in talking with people who are doing TSM, they don't want to go to their primary care doctor to get a prescription. They can get a prescription from or one of these other telehealth platforms, or even India or whatever, and they don't have to talk to their doctor about it. But and if you're willing to be patient for a period of time and throw in some alcohol-free days, you can gradually take the Band-Aid off without having to talk to your doctor about it. But it's a failure of medical practice when in a space of a week or two, we can get to that point and you don't have to have a whole year of heavy drinking. And heavy drinking can affect your relationships. Your spouse may not be happy with your drinking. It can affect your work performance. For a year, your work performance is bad. For a whole year, your liver is subject to too much alcohol. For a whole year, your heart subject to too much alcohol. For a whole year, your brain is subject to too much alcohol. Dude, that's the cost of taking the Band-Aid off slowly. So if you can do it safely and effectively as a detox, that's my general recommendation. But having said that, theoretically, it could work by you having control over how much you drink and then gradually reducing your drinking to avoid the horrible withdrawal. But for no means, if you feel like you've reached a plateau and you're still drinking, you hear all these great reports how people take naltrexone and miraculously they don't want to ever have another binge again the rest of their life. That doesn't mean it's not working for you. It just means you're at a different stage in how alcohol is affecting your body.
Yeah,
I have a couple more slides which distill everything I've said. I asked ChatGPT, I said, usually when I give these kind of talks, people walk away and they say, that must have been really good, but I don't know what the hell the guy said. So I said, ChatGPT, give me some lines to tell people that they could walk away with and understand what I just said. So with your permission, can I go through this?
Oh, wait, we still have a couple more questions.
More questions. Okay, I'm sorry. Never
Uh,
mind.
I think, Dave, you had a question. Dave T.
Mine that was in the chat. Yeah, I was just going to clarify something, Dr. V. That when we're talking about using, so hypothetically, if somebody has a combination of reward drinking and sedation drinking to relieve anxiety, and could they hypothetically on one day address the anxiety with a benzo, as you were saying before, but then on the next day they're in a completely different setting and it's the reward-based side of their drinking, use naltrexone paired with drinking. Is that enough gap between the two? Is that dance possible between those two things to address the two sides of their drinking?
Yeah, I do it all the time for my patients. Yeah,
Okay.
there's some people who have a primary anxiety disorder. I have a patient that I saw today who I've been seeing for 20 years now. And he takes naltrexone, and he also has a prescription for oxazepam. And when his anxiety is too high, he takes an oxazepam. Has a prescription for 20 years now, has never abused it. He only takes it when he needs it. And it's really helpful right now because right now, this week, he's going through a stressful situation with his boss and job situation. And he's used naltrexone for a lot of years. He says now, what's curious is that even though he's really stressed and he used to drink when he was, quote, stressed, the thought doesn't even occur to him to want to use alcohol to cope with the stress anymore. He'll use a benzo when he's stressed, but the idea of using alcohol when he's stressed doesn't even enter the picture. And, he's been taking naltrexone for, decades now. And he's worried that he's losing weight. I said, well, the naltrexone could be contributing to weight loss. So I said, just use naltrexone on an as needed basis. So it's basically, if he's going to be in a high risk situation, he'll pull out his naltrexone and use naltrexone then. but he's been sort of reluctant to give up his safety net of taking naltrexone. And I said, well, after 20 years, I think it's okay that you don't have to take the naltrexone, but it's around if you need it. So, but he has a combination of that he does have a primary anxiety disorder and he also has an alcohol use disorder. And so I treat both conditions.
Perfect. Thanks for clarifying.
Great. Blaine.
Yeah, I'll be brief and thanks, Doctor, for your time tonight. This has been very helpful. Kind of what Joe was saying, I'm similar in the sense I've been doing this for about 2.5 months. I've had pretty good results. I was probably, 6 to 8 good strong cocktails a night, and I've gotten that down to half of that, probably less. I think what I'm struggling with, and maybe it's just time, giving it more time, is getting that AF day in. I haven't got there. And there's for example, last night I had 2 drinks, which for me is a miracle that that's an option. And then I poured a third, and dang it, I actually put the third in the fridge to save it for the next day because I just didn't eat it. But
you have control.
But there's a but.
Go ahead.
But then that sedation part of getting to sleep, and I kind of was asleep and kind of restless and kind of jerky or whatever you want to call it. And so, an hour or 2 into that, I got up and drank that drink. And I went to bed and slept, and I was fine. At least I'm not hungover these days. But and I've actually got to the point of I had 1.5 drinks. I think it was like a week or 2 ago on a particular night. So I'm close, but it's just I feel like I've got this attachment of, okay, I'm going to be alone with this and not have that nighttime blanket, if you will. Because I recognize that is something I've got to get to have some AF days at some point. Close, and it's certainly on a trajectory of going down. When I look at my tracking, it's in the right way. But anyway, just thoughts there.
So hopefully you can look at your pattern now as data and say, here's where I am. So, at 2.5 drinks, it's not quite enough to block the withdrawal. And so when it's time to go to bed, I feel a little bit more irritable. I have more trouble sleeping. That's the difficulty getting to sleep is part of the withdrawal. At 5 drinks, it covers it nicely. At 2.5, it doesn't quite cover it. So that's where you are right now.
Right.
It's not a failure of will. It's not a failure of naltrexone. It's biochemically, that's where you are. And you can decide, I'm going to have a couple nights where I don't sleep, or you can decide, I'm going to have a drink because I really want to go to sleep tonight. And I'm at a 3.5 drink phase in my recovery right now. Next week, hopefully, it'll be a 3 drink phase.
But I think I just got to get there and say, listen, okay, tonight, what can I just deal with it tonight? And it's not
so
horrible.
You can anticipate, I'm only having 2 drinks and I'm at a 3.5 drink phase. I'm going to feel kind of crappy tonight. I expect that. Maybe I'll take a melatonin or something, or just have a night where I don't sleep well. And you don't feel like it's a failure. You don't feel like I have to have a drink or I want, this is what you can expect. And it feels completely different. The whole process feels different when you say, oh, I'm not going to have to live this way the rest of my life. My body's going to eventually adapt to this, and I won't have nights like this anymore.
Yeah, no, that's helpful. I mean, I was literally thinking tonight and I hadn't thought about it, but I honestly don't think, even if I wanted to go have 5 to 8 drinks, I don't think I could do it. And I've done that for a while. That's not a new thing. I don't think I could handle 5 to 8, honestly. And just in 2.5 months, it's been not a religious person, but well, for lack of a different word than miracle, it's anyway been amazing. So thank you.
Yeah, but what tonight people are describing exactly the model I've been talking about. It's perfect examples.
Yep. Ingo has a question that I think is a natural segue into your last slide. So I'm going to ask him to unmute and ask his question, but I think it naturally flows into your finale. Go ahead, Ingo. You got to unmute.
Oh, yes.
Hey.
I found the button, yeah. Thank you very much for this very nice session. It's very interesting. It's so interesting that I think I want to promote that naltrexone even more. And I'm doing it already, and I'm staying in Germany. Now, my challenge is how to convince a doctor to prescribe it to you.
Yeah.
90% of the people which I can actually motivate to go for the TSM fail by getting a prescription. And have you got some tips how to ask the doctor for it?
Yeah. So this is a whole nother session, but it's even so in Germany, there's been some absolutely wonderful study. I think Carl Mann did some studies that shows naltrexone is effective. I believe Germany is part of the European Union where naltrexone has been approved as a medicine to take to treat alcohol use disorder. So it's a legitimate.
Not really. It's nalmefene, which is
Oh, you're correct. Nalmefene. You're correct. As a matter of fact, for nalmefene, I was involved in some of the studies where it got approval because they used. I designed something called the Brenda approach, and they asked me to design a manual, and that was used with the nalmefene study. So you're absolutely right. But nalmefene works just as well as naltrexone. So you present him with, here are the facts, here's the data, here's a approved medicine that can help me with my drinking. This is the dose that you use. You know, I come to you asking for your help. It's not easy for me to say I have problems with my drinking because often people feel bad about that. But I'm coming to you and asking you to help me with this. Here's the data. If you have any questions, there's a variety of sources where you can look up information. You can right now, a lot of the doctors are using something called, open evidence. So there's an AI program that describes how to use it. There's tons of resources that describe how you use it. If he has another question, I'd be happy to talk to him. Now, I can't talk to him in German, but if he knows English, I'd be happy to talk to him. Eventually, I'm going to put everything down and have it translated into German, so I'll be able to hear it that way. So there'd be no excuse for him not to feel comfortable with his very safe and very effective medicines or class of medicines, opiate antagonists. If that doesn't work, then you might have to go the route that Claudia Christian went. She wound up getting her medicine from India.
Yeah. Anyway, for me it was easy. For me, it was easy to get it because I'm an experienced patient, so I know how to talk to doctors in a way to get my medicine.
Well, we need to have a script.
But most people, when they just go, they don't succeed. Like I was saying, to get it, I say, I'm drinking too much. I have to reduce my drinking and have to do that quick. I can't go for therapy now because my job is on the line. So can you please prescribe it to me so that I have a quick fix right now? Afterwards, I will think about a therapy. Yeah. So yes, I get it this way, but not. Most people which I motivate to go, they come back and say, sorry, no doctor wants to prescribe it.
This is the issue that my whole Substack series is about, is the failure of medicine to address this issue. This is a battle I've been fighting for 30 years. So naltrexone was FDA approved in 1994, over 30 years ago. And I've been fighting the same battle. And the good news is things are changing. But they're changing not because all of a sudden the doctors started getting smart. They're not changing because the addiction treatment programs are suddenly getting smart. They're changing because people like you and Claudia, Kristen, and Katie Lane, and Steve Wagner have helped establish a grassroots movement where people are demanding it. And they're getting doctors to look it up. They're getting addiction programs to offer it. And things are changing.
I'm also trying to do that. For example, if you look on the internet, there's nothing in German. There's no German literature about the TSM. That's why I've even translated the whole book of Dr. Escapa into German. Now I'm having the challenge. I want to find out, am I allowed to publish it or not? and I don't know how to get hold of this Dr. Estapa.
Yeah. So Dr. Escapa, Steve, maybe we can help him get connected with Dr. Scappa. But last time we tried to contact him, I don't think he was talking to us very much. I don't know. What do you think, Steve? Would he be able to give approval to translate it?
Well,
Or?
I think he could, but here's the thing I worry about, Joe, is I find the book is outdated, okay, because it doesn't give the complete story that you just went through tonight, okay. We need a new book, to be honest, okay, because the way that the Cure for Alcoholism reads is that it's rather reductionist, and it relies upon extinguishing the learned behavior. And we just saw that there's so much more to it than that. Um, there's very important parts of that book that need to be included, but we really need a new version.
I mean, I would be happy to have what we talked about tonight to be translated into German. I'd be happy to have my videos where we could have them translated into German. But you're absolutely right. I mean, I'm working with some folks in Canada right now, and I had a conversation with a journalist from England about this very issue. So we're trying to make this international, and it's a worldwide problem. Yeah, prescription of naltrexone or nalmefene is still very low in Europe, in Canada, in Asia, and it's something that we really have to change. Now, the only thing I can say is I get a report of people who are reading my articles, and actually, I'm really popular for some reason in China and Russia. I don't know. People are reading a lot of my articles in those countries for some reason, but it's an international issue, and we really need to address it from that perspective. And I was just talking to Steve. We need to translate the information that we're talking about into various countries so that people can hear this message. And again, it's coming from the grassroots. I mean, my papers, I'm sure have been translated. The Brenda book that I wrote has been translated into many languages. The pen alcohol craving scale is in German, and so and is in 11 other different languages. But the idea of using an opiate antagonist to treat alcohol addiction is not received worldwide acceptance yet, and we really have to change that. So I really endorse your efforts, and anything we can do to help support that, we should do that. So, and if you find something that works, help teach us, because we still have a long way to go.
No, see, I want to that people have got information, because the only information is some translated things. AI translates it from the English, but there's nothing really written in German. There's a book, The Cure. It is a manual, actually, to describe it, which I think is a good start.
Yes.
Yeah.
Well, we should whip something like that up.
Yeah.
That's
the
our
book
task.
from Katie Herzog is very good.
I
Also,
wrote
that
the
can be
forward to that. Yes.
Yeah. That one should also, if it also can be translated
Yes.
and made available in Germany, that would be
I
great.
will, when I talk to Katie, I'll ask her if she can have it translated. Yeah. Yeah. No, it's a great book. What she wrote was a wonderful book, and she spent a lot of time really trying to get in to learn all about it and the limitations and that sort of thing. She's a good journalist, and she wrote a great book. So we have to get all that stuff out there. You're right. You're absolutely right. So,
okay, thanks.
So thank you for your efforts. And again, I'm so happy to talk to groups like this. And what was it, a couple years ago that we met Steve and invited me to talk to this group, and it started a whole bunch of things. It was the beginning, right?
Right. And we need to have you back more often. That's for sure. That's been my fault. But why don't we give you the opportunity to sum things up? And I think we've covered most people's questions. I hope I didn't miss somebody. It was a little confusing there. If I did and you have something burning, put it in the chat and we'll try to make sure. Otherwise, I'll let you sum up.
Well, this is what AI says I should have said instead of what I said. It said, nobody's going to understand what you sound too much like a college professor, but that's how I normally think and talk. So let me try it this way. Can you see my slide?
Yep.
Okay. At first, pleasure wins. Okay. That's the first thing to keep in mind. The A process is strong, the buzz is real. The B process is mild and brief. So first, pleasure wins. Let's see. Over time, craving wins. So the pleasure leads to craving. And the more you drink, the more the craving takes over. The A process weakens and the B process grows stronger with every drinking episode. Okay. And over time, you stop drinking for the pleasure of it. The buzz fades, drinking no longer feels the way it used to. So you're not getting the high so much, but you start drinking for the relief. So that's a really critical thing. Once you start moving into that phase, things change in terms of the kind of outcome you can expect when you take naltrexone. The goal shifts not to feel good, but to stop feeling bad. Then there's the reward drinking, chasing the buzz, versus the sedation drinking, relief and anxiety. You drink to feel normal. The GABA system is dominated. Naltrexone has a limited effect on the sedation drinking. On the other hand, the reward drinking to feel good, the A process is dominant. Naltrexone works well here. It blocks the reward and starves the craving. So how do you know if you're one of those sedation drinkers? So you drink maybe in the morning, or drinking is the first thing you do to steady yourself. People who tend to drink a little bit throughout the whole day, not in like short bursts of drinking. You get little or no pleasure from drinking anymore. And if you try to stop drinking, you get physical symptoms such as tremor, sweating, anxiety. And naltrexone is not effective in reducing your cravings. If several of these describe you, the GABA pathway may be dominant. So again, you could do the Band-Aid off slowly or the Band-Aid off quickly by talking to a physician. And if you're in that sedative, if you're a sedative kind of drinker, you can reach that plateau phase where your drinking has gone from 7 to 8 to blackouts to 5 or 6, but you can't seem to get it below that. If you try and go below that, what do we hear? You have trouble with sleeping. Or you feel out of sorts. Or something inside you says, I'm anxious, I need a drink. And you don't know how to interpret it. I'm telling you, the way to interpret it is your body's in some mild withdrawal, and that's eliciting craving for the alcohol to take away the withdrawal. So the progress seems like it stalls at that phase. People will say things like, I don't enjoy it, but I still need it. This is sedative drinking. The biology has shifted. Willpower alone can't fix a GABA system that has reorganized itself. So what's happening on naltrexone? You reduce the A process, so it blocks the opioid receptors, shutting off the endorphin surge. The reward signal weakens, and over repeated experiences, the brain can unlearn the drinking reward association. And if you stop getting that A process spike, over time, the B process has nothing to react against. It doesn't get triggered anymore. Craving will eventually diminish, but that's going to take weeks or months. And the B process does not vanish overnight. Over time, the brain will gradually learn the drinking habit is no longer rewarded at a biological level. How naltrexone works. It blocks the reward. It blocks reinforcement. It weakens the A process. And as you get less of an A process, over time, the B process can fade but that can take some time for that to occur. And so with naltrexone, you've changed the biology. You weaken the reward pathway. I don't know. I disagree with AI, but it always goes back to this, your brain is rewiring itself. That's so much in the internet. I can't get it to rewire the damn AI. It has to talk about rewiring all the time, but that's what it says. So apparently that's the terminology. The brain's rewiring itself. I say you don't need an electrician to rewire itself to treat people, but that's a whole nother thing. That's AI. So when you change the biology, eventually the behavior will follow. First, the biology shifts, then the behavior reinforces it. And here's how to break the plateau. Create gaps. Avoid drinking every day. Gaps between sessions let the B process fade rather than stay primed. Don't overdrink. Don't drink past the point of the buzz, because that gets the B process strong again. The goal is less, not more. And add structure. Regular sleep, exercise, stress management can all reduce the GABA system hyperexcitability between sessions. Breaking the plateau. The plateau is information. It's data. Use it. Create gaps between drinking sessions to let the B process fade more quickly. Don't overdrink. Large doses only reinforce the very neurobiology that we're trying to extinguish. Add structure, sleep, exercise, social connection, all reduces the GABA hyperexcitability, the baseline anxiety. The urge is not failure. It's the B process doing what it has always done. That biology takes time to change. Persistence is the treatment. It's the brain slowly adapting. Extinction can take weeks or months, not days. And each exposure on naltrexone is progress, even when it doesn't feel like it. I think I would have worded that a little bit differently, but that's in there. Naltrexone starts the process. It removes the biological reinforcement. The brain does the rest gradually, session by session. And you finish it. As the biology changes, behavior follows, and that's how extinction works. There it is. So that's the summary of what I just said.
Great.
You can let me know if that made more sense to people than my introductory presentation.
I think it is additive. Okay, it's additive. Yeah.
It's okay to say, yeah, finally it makes sense. All this other stuff didn't make any sense.
Well, it's helpful to take different angles at stuff. Okay, so and to hear it different ways. So, really, thank you so much for all your time putting this together. Thank you so much for addressing all these questions. There'll be a ton of questions that come up. Thank you to all of you who took the time to attend. Hopefully, this has been useful. I know it's been tremendously useful for me. And we will get the recording up and out to in places where people can see it, and look forward to having you back again soon. You could tell us the various ways that naltrexone works, since you promised that you could do a whole session on that. I know you're always good for topics, but I really hope that people take away from this that this is a really nuanced disorder, and it changes over time. It depends on where you are, and it takes a lot of self-awareness and understanding of your own system to understand where you are, and then to use the tools to resolve it. So thank you, everybody. Thank you, Joe.
I just want to leave with this, that if you felt that you got something out of this, if it's helpful for you, I appreciate the thanks. But what I would really love for you to do is teach another person this stuff. Let's spread the word. And if everyone teaches one other person, then it will grow exponentially. and that's what we need to do. And then check out the Substack and keep reading all this stuff and help teach each other and bring more people on board with this. It's the movement is growing, and we're going to get it to keep growing.
Great. Super. Thank you, everybody. And we'll say good night then.